Welcome to the deep dive. Today we're jumping into, honestly, one of the most critical chapters for understanding pathophysiology.
Absolutely. Chapter 26, Disorders of Blood Flow and Blood Pressure Regulation. It really underpins so much else.
Right, because if blood isn't flowing right or the pressure's off, well, nothing else works properly, does it?
Exactly. You can have immediate life threats like shock from low pressure or these slow, damaging processes like hypertension, just wrecking vessels over decades.
So our goal here is to give you that solid foundation, that efficient path through this dense material. We'll go from the tiny cells lining the vessels all the way up to the big systemic problems.
Yeah, structuring it logically. We'll cover the key players, endothelium, lipoproteins, the Virchow triad for clots.
And get those pressure definitions straight. Systolic, diastolic, MAP, all that.
Okay, let's get started. So, first things first, the basic architecture.
Yeah.
Most blood vessels, arteries, veins, they have three layers. You've got the outer tunica externa, the middle tunica media, and the inner tunica intima.
Except for capillaries, right? They're the exception.
That's right. Capillaries are where the real action happens, the exchange. So they're super thin, just a single layer of these specialized endothelial cells, plus some supporting cells called pericytes.
And that single layer, the endothelium, it sounds fragile, but it's incredibly important, isn't it? Like miles and miles of it.
Oh, absolutely. Around 60,000 miles, they estimate.
Yeah.
And it's not just a passive lining, it's a dynamic organ. It controls clotting, adjusts blood flow, manages immune responses. It's vital for homeostasis.
So when things go wrong there, that's endothelial dysfunction.
Precisely. It's often the first step in vascular disease. Stress, inflammation, high lipids, low oxygen. They can all damage the endothelium, changing how it functions and even its structure. That kicks off a lot of problems.
Okay. And then in that middle layer, the tunica media, we have the vascular smooth muscle cells, the VSCMs.
Yep, their main job is contracting and relaxing to change the vessel diameter. That's how we control peripheral resistance and blood flow distribution.
But they also play a role in disease.
They do. When there's injury or inflammation, these VSCMs can actually migrate from the media into the intima, and they start dividing, proliferating.
So they thicken the wall.
Exactly. It's part of a repair response, but it can go haywire. That proliferation is a key element in building up those atherosclerotic plaques we'll talk about later.
Okay, that makes sense. Now let's talk pressure. We hear these numbers all the time. Systolic, that's the top number, the peak pressure.
Right, ideally below 120 millimeter Hg. It reflects how forcefully the heart ejects blood, the stroke volume, and also how stretchy or distensible your arteries are.
And diastolic, the bottom number, ideally below 80. What's that telling us?
Diastolic pressure reflects what's happening when the heart relaxes between beats. It's really about the resistance in the peripheral vessels, that background squeeze maintained by the VSCMs after the aortic valve has snapped shut.
So the difference between them, systolic minus diastolic, that's the pulse pressure, usually around 40.
Correct. And then there's mean arterial pressure, MAP. Why is that one so important?
MAP is essentially the average pressure across the whole cardiac cycle. Think of it as the average pressure driving blood into your tissues. We like to see it between 90 and 100 millimeter Hg.
Right, because it's the best indicator of whether your organs are actually getting perfused with enough blood. It's calculated roughly as cardiac output times peripheral vascular resistance.
So our body needs ways to keep that MAP stable, especially with quick changes, like standing up.
Absolutely. That's where acute regulation comes in, working in seconds to minutes. The nervous system is key here. You have baroreceptors, pressure sensors, mainly in your carotid arteries and aorta.
They sense stretch.
Yeah, if pressure drops, they sense less stretch, and they signal the brainstem almost instantly. The autonomic nervous system then kicks in, increases heart rate, constricts blood vessels to bring pressure right back up.
Fast response. But what about more sustained pressure issues? That brings us to hormones, right? And the big one, RAAS.
Definitely. The renin-angiotensin-aldosterone system. This is crucial for both short-term and longer-term control if blood pressure or blood flow to the kidneys drops.
The kidneys notice.
Yes, specialized cells there release an enzyme called renin. Renin starts a chain reaction. It converts a protein called angiotensinogen, which is always floating around from the liver, into angiotensin the first.
Okay, angiotensin the first. Is that the active one?
Not quite yet. Angiotensin then travels through the bloodstream, and when it hits the lungs, an enzyme called ACE, angiotensin-converting enzyme, converts it into angiotensin the second.
Ah, angiotensin the second. That's the powerhouse.
That's the one. It's got a really potent effect. First, it's a very strong vasoconstrictor. It clamps down blood vessels system-wide, immediately increasing peripheral resistance and thus blood pressure.
Okay, instant pressure boost. What else?
Second, it targets the adrenal glands, making them release aldosterone, and aldosterone works on the kidneys.
Telling them to hold on to salt and water.
Exactly. Retaining sodium and water follows sodium. This increases your overall blood volume, which helps maintain pressure over the longer term. It bridges acute control to long-term regulation.
Which is primarily the kidney's job, managing that fluid volume.
Right. Over the long haul, the kidneys are the master regulators. If blood pressure drifts too high, they naturally start excreting more salt, that's pressure natriuresis, and more water pressure diuresis, to bring the volume, and therefore the pressure, back down to its set point.
Okay, so we have the pipes and the pressure regulation. Now let's talk about what gums up the works. Lipids and dyslipidemia.
Yeah, dyslipidemia just means an unhealthy balance of lipids, triglycerides, phospholipids, cholesterol in the blood. And since lipids don't dissolve in blood, they need carriers, lipoproteins.
And there are different types. VLDL.
Very low density lipoprotein. Its main job is transporting triglycerides that your body makes, mostly from the liver out to tissues.
But the one we hear most about is LDL, low-density lipoprotein.
That's the main carrier of cholesterol to the cells. And yeah, it's often called the bad cholesterol because high levels are strongly linked to atherosclerosis. It's atherogenic.
How does the body normally get rid of LDL?
Mostly through specific LDL receptors, about 75% of which are on liver cells. They bind LDL and pull it out of circulation. Healthy process.
But if there's too much LDL or the receptors aren't working well?
Then the backup system kicks in, the scavenger pathway. Immune cells, specifically macrophages in the artery walls, start gobbling up excess LDL, especially if it's become oxidized, sort of damaged.
And that's bad, even though they're cleaning up.
Ironically, yes. These macrophages get so full of fatty LDL, they transform into what we call foam cells. And collections of these foam cells form the earliest visible sign of atherosclerosis, the fatty streak. It's the beginning of a plaque.
Okay. Is there a good cholesterol carrier?
Yes, HDL, high-density lipoprotein, it does the opposite. It facilitates reverse cholesterol transport, picking up excess cholesterol from tissues, including from those plaques, and taking it back to the liver for disposal. So HDL is generally protective.
Got it. So this whole process, the LDL buildup, foam cells, inflammation, that leads to atherosclerosis, hardening of the arteries.
Right. It's the underlying cause of so much cardiovascular disease. And the risk factors are pretty well known. High cholesterol, especially high LDL, smoking, high blood pressure, diabetes.
The source mentioned a scary statistic. If you have hypertension, diabetes, and high lipids, your risk goes up like 20 times.
Yeah, it's a deadly combination. They potentiate each other. Other markers like C-reactive proteins, CRP, indicating inflammation, and homocysteine levels are also implicated.
So let's trace the steps of a plaque forming. Starts with that endothelial injury or dysfunction we talked about.
Right. Then monocytes, a type of white blood cell, are attracted to the site. They squeeze into the vessel wall, mature into macrophages, and start eating the oxidized LDL, becoming foam cells. That's the fatty streak.
Then what?
Then those smooth muscle cells, VSCMs we mentioned earlier, get involved. They migrate from the media into the intima, proliferate, and start laying down extracellular matrix, like collagen. This forms a fibrous cap over the fatty core.
So it becomes a more complex plaque.
Exactly, a fibrous atheromatous plaque. Now here's a critical point. The stability of that plaque depends a lot on the thickness of that fibrous cap.
So a thick cap is relatively stable.
Generally, yes. It walls off the fatty thrombogenic core. But if the cap is thin and inflamed, the plaque is considered vulnerable. It can rupture or ulcerate easily.
And if it ruptures?
That exposes the fatty core to the blood, which triggers rapid clot formation, a thrombus right on top of the plaque, and that thrombus can suddenly block the artery.
Which causes things like heart attacks or strokes.
Precisely. Or acute blockages in the limbs.
Let's talk about those acute limb blockages. Acute arterial occlusion. The book mentions the 7 PS.
Classic description, yeah. Pistol shot, meaning sudden onset. Pallor, paleness. Polar coldness, pulselessness, pain, paresthesia, numbness, tingling, and paralysis. It's an emergency.
And if the blockage is more gradual, due to atherosclerosis building up over time in the leg.
That's peripheral artery disease, or PAD. The hallmark symptom there is intermittent claudication.
Which is?
It's pain, cramping, or fatigue, usually in the calf muscle, that comes on predictably with walking a certain distance and goes away quickly with rest. It's basically the leg muscles screaming for more oxygen than the narrowed arteries can deliver during exercise.
The chapter also mentioned a couple of other arterial issues. Thromboangiitis Obliterans?
Or Burger disease, yeah. It's different from atherosclerosis. It's an inflammatory condition, a vasculitis, that affects small and medium arteries and veins, usually in the limbs, causes thrombus formation, strongly linked to heavy smoking, especially in younger men.
And Raynaud phenomena.
That's more of a functional disorder. Intense vasospasm clamping down of the arteries in the fingers and toes, usually triggered by cold or emotional stress, causes distinct color changes. White, pallor from lack of blood flow, then blue, cyanosis from deoxygenated blood pooling, then red, flushing as blood flow returns.
Okay, moving from blockages to structural failures. Aneurysms, basically a bulge in the vessel wall.
Exactly, an abnormal localized dilation or outpouching of a blood vessel or the heart wall.
And there's a difference between true and false aneurysms.
Yes. A true aneurysm involves all three layers of the vessel wall bulging out. Think of common types like berry aneurysms in the brain's circle of Willis, or fusiform, spindle-shaped, and saccular berry-like aneurysms in the aorta. The wall is weakened but intact.
Okay, so what's a false aneurysm?
A false aneurysm or pseudoaneurysm isn't really a dilation of the wall itself. It's actually a localized tear or rupture in the inner layers where blood leaks out but is contained by the outer layer or surrounding tissues, forming a pulsating blood-filled cavity.
So like a contained leak.
Kinda, yeah. Now, the big danger with any aneurysm, true or false, is rupture.
And the risk increases with size.
Directly. There's a physical principle involved, Laplace's law, essentially. The tension on the vessel wall is proportional to the pressure inside times the radius. So as the aneurysm gets bigger, radius increases, the wall tension goes way up, making it much more likely to tear or burst. Size matters a lot.
That leads us to aortic dissection, which sounds terrifying. It's a type of false aneurysm.
It is, and it's an acute, life-threatening emergency. It involves a tear in the intima, the inner lining of the aorta. Blood surges through that tear into the wall itself, splitting the layers apart, creating a false channel within the aortic wall.
What causes that?
The biggest risk factors are hypertension, just the constant high-pressure stress on the aortic wall, and conditions that weaken the medial layer, the middle layer, with the smooth muscle and elastic fibers. Sometimes it's connective tissue disorders, but often it's just degeneration associated with aging and chronic high pressure.
And the pain is distinctive.
Extremely. It's classically described as sudden, severe, excruciating pain, often described as tearing or ripping, where you feel it can give a clue. Pain in the anterior chest often suggests the ascending aorta is involved, while pain radiating to the back between the shoulder blades points more towards the descending aorta.
We spend so much time on arteries, the high-pressure side, but the veins have their own challenges, right? Getting blood back to the heart against gravity.
Absolutely. The venous system is a low-pressure, high-volume system. The veins have thinner walls and less muscle than arteries. They rely heavily on two things to get blood back up, especially from the legs.
One is the valves inside the veins.
Correct. Little one-way valves that prevent blood from flowing backward. And the second is the skeletal muscle pump.
How does that work?
When you walk or move your leg muscles, they contract and squeeze the deep veins embedded within them. This pushes blood upward past the valves. When the muscles relax, the valves close, preventing backflow, and the veins refill from below. It's essential.
So if you stand still for a long time, or those valves fail, problems.
Big problems. Prolonged standing increases pressure in the leg veins. Things like obesity or pregnancy increase intra-abdominal pressure, making it harder for blood to return from the legs. This can cause the veins to stretch, become dilated and tortuous, and the valves can become incompetent. They don't close properly.
Leading to varicose veins.
Exactly. Those bulging, ropey veins you can often see, usually in the legs. They result from that valve failure and venous dilation.
And if that situation persists with blood pooling and high pressure in the veins long term.
That leads to chronic venous insufficiency, or CVI. The sustained high venous pressure causes fluid to leak out into the tissues, leading to edema, congestion, and impaired nutrient delivery to the skin and subcutaneous tissue.
What does that look like clinically?
You often see changes in the skin, particularly around the ankles. Stasis dermatitis, the skin becomes thin, shiny, often brownish or bluish red due to hemosiderin deposits from broken down red blood cells. And crucially, it can lead to venous ulcers.
Ulcers that are hard to heal.
Very hard. CVI is the most common cause of lower leg ulcers. The tissue is just too unhealthy due to the poor circulation and chronic inflammation.
Okay, another major venous issue, clots. Deep venous thrombosis, DVT.
Right. A DVT is the formation of a blood clot, a thrombus, within a deep vein, most commonly in the legs. It causes inflammation of the vein wall known as thrombophlebitis.
And the cause comes down to that classic concept.
The Virchow triad. You absolutely need to know this. It states that DVT typically results from a combination of 3 factors. 1, stasis of blood. Slow or stopped blood flow, like during prolonged bed rest, immobilization after surgery, or even long flights.
Okay, stasis 2.
Increased blood coagulability or hypercoagulability. The blood is stickier, more prone to clotting. This can be due to genetic factors, cancer, pregnancy, oral contraceptives, or dehydration.
And the third part of the triad.
Vessel wall injury, damage to the endothelial lining of the vein. This can happen from trauma, surgery, IV catheters, or inflammation. When you have elements from these 3 categories together, the risk of DVT goes way up.
All right, let's wrap up by looking at failures of the regulation systems themselves, starting with the big one, hypertension or high blood pressure, sustained high pressure.
Right. In most cases, like over 90%, are primary or essential hypertension, meaning we can't pinpoint a single specific cause. It seems to be a complex mix of genetics, environmental factors, lifestyle.
As opposed to secondary hypertension.
Exactly. Secondary HTN is high blood pressure that is caused by some other underlying condition. Kidney disease is a major culprit if the kidneys aren't filtering properly, or if the arteries supplying the kidneys are narrowed, renovascular hypertension. It can trigger the RAAS system inappropriately and drive up pressure. Adrenal disorders can do it too.
But for primary HTN, lifestyle factors are huge modifiable risks, right?
Definitely. Diet, especially high salt intake in salt-sensitive people, dyslipidemia, excessive alcohol consumption, lack of exercise, smoking, and obesity is a big one.
Especially central obesity,
Yeah.
the belly fat.
Yes, there's a strong link there. Adipose tissue, particularly visceral fat, is metabolically active. It releases substances, including leptin, which seems to stimulate the sympathetic nervous system, contributing to higher pressure. Obstructive sleep apnea, OSA, is another important risk factor, often linked to obesity too.
The scary thing about primary hypertension is that it's often silent for years.
That's why it's called the silent killer. People often feel fine until significant target organ damage has already occurred. The organs most vulnerable are those with rich blood supplies or those highly sensitive to pressure changes.
Like the heart.
Absolutely. Constantly pumping against high resistance makes the left ventricle work harder. It hypertrophies, gets thicker initially as a compensation, but eventually it can fail, leading to heart failure.
And the kidneys.
High pressure damages the small blood vessels in the kidneys, leading to nephrosclerosis, hardening of the kidney arteries, which impairs kidney function and can lead to chronic kidney disease. It's a vicious cycle, as damaged kidneys are less able to regulate pressure.
Brain. Eyes.
Yep. Hypertension is a major risk factor for stroke, both ischemic and hemorrhagic. It also contributes to cognitive impairment and dementia over time. In the eyes, you get hypertensive retinopathy, visible damage to the retinal blood vessels, like narrowing, hemorrhages, even swelling of the optic disc.
And the most acute danger.
A hypertensive emergency. This is when blood pressure skyrockets, usually above 1/8 and 120 millimeter HHG, and there's evidence of acute ongoing target organ damage like encephalopathy, stroke, heart attack, acute kidney failure. This requires immediate hospitalization and treatment to lower the pressure safely.
Okay, now flip side. Hypotension. Low pressure.
Yeah.
Specifically, orthostatic hypotension.
Right, sometimes called postural hypotension. It's defined as an abnormal drop in blood pressure when moving from lying sitting to standing, specifically a drop of at least 20 millimeter Hg in systolic or 10 millimeter Hg in diastolic pressure within 3 minutes of standing.
What causes that drop?
Gravity. When you stand up, gravity pulls blood downward, about 500 to 700 milliliters. That's a fair bit of volume, pools temporarily in your legs and trunk.
Like half a liter or more shifts down.
Yeah. Normally, your body compensates instantly. Those baroreceptors fire, the autonomic nervous system kicks in, heart rate increases, vessels constrict, the muscle pump helps push blood back up.
But in orthostatic hypotension, that compensation fails.
Exactly. The response is too slow or inadequate. So blood pressure drops, reducing blood flow to the brain, causing symptoms like dizziness, lightheadedness, blurred vision, weakness, and sometimes fainting or syncope.
What makes that compensation fail?
Several things. Reduced blood volume is a big one. Dehydration or side effects from diuretics. Aging is a factor. Vessels get stiffer. Baroreceptor sensitivity might decline. Certain medications, especially blood pressure meds, can contribute. And diseases affecting the autonomic nervous system, like Parkinson's or advanced diabetes, can impair the reflex response. Hashtag outro. So we've really covered the gamut there, from the delicate endothelial lining and how it can dysfunction, through the slow buildup of atherosclerosis, the dramatic wall failures and aneurysms and dissections, venous issues like DVTs, and finally the systemic regulation failures of hypertension and orthostatic hypotension.
It really highlights how much relies on that constant, delicate balance between blood flow, vessel resistance, and fluid volume, doesn't it?
Absolutely. And how often the most dangerous processes like atherosclerosis or primary hypertension develop silently over many years.
So thinking about the big picture here, what's the key takeaway for someone trying to grasp this chapter?
I think it's really understanding the interplay, how the kidneys manage volume long term, how the vessels respond to mechanical stress like pressure and biochemical stress like lipids, and how failures in these systems lead to specific diseases. It's all connected.
Okay. And you wanted to leave our listeners with a final thought, something to chew on.
Yeah, just thinking about those regulatory systems. The chapter mentions how things like sleep quality impact blood pressure regulation, specifically that lack of the normal nighttime dip in blood pressure seen in people with poor sleep or sleep apnea is a predictor of bad cardiovascular outcomes.
Interesting connection.
It makes you wonder, doesn't it? What other seemingly small everyday habits or factors might be quietly disrupting that crucial balance within our 60,000 miles of blood vessels without us even realizing it?
That's definitely something to think about. Great point to end on. Thank you for guiding us through that complex material.
My pleasure.
And thank you all for joining us for this deep dive. We hope this breakdown helps you master Chapter 26.